Let's go ahead and learn everything we need to know about diabetes for our Medsurg or adult health nursing course. We're learning now about diabetes type 2. Diabetes type 1 is a separate patho, slightly separate treatment. We have that in a separate video. But diabetes type 2, let's start with the pathophysiology. It's a chronic disease of insulin resistance, and it also has a little bit of insulin deficiency. Let's explain how that differs from diabetes type 1. First of all, diabetes type 2 is much more common. 90 to 95% of all patients with diabetes have type 2. So type 1, which we're not covering in this video, is much more uncommon. But diabetes type 2, which is the more common one, is primarily a disease of insulin resistance. What does that mean? Every time we eat anything that has sugar in it, the sugar ends up in our bloodstream, and from there it has to go into the cell. In order to get into the cell, it needs insulin. The insulin and the sugar go into the cell. In the case of insulin resistance, the cells are resistant to the insulin and the sugar entering the cells. Because the cells don't allow the sugar and the insulin to come in, the sugar and the insulin stay in the bloodstream. Because they stay in the bloodstream sugar level, which is our serum glucose, goes up and up and up. So that's the part of insulin resistance. That's the key characteristic of diabetes type 2. Now, it also has a little bit of insulin deficiency, that we're not getting enough insulin relative to how much sugar we have in our body. Over time, very often, especially in uncontrolled diabetes type 2, they will end up as insulin dependent type 2 diabetics for a bunch of reasons that we're not really going to go into in this video. Next, when patients have type 2 diabetes, based again, still on the pathophysiology, their blood sugar level is going to go up and up and up, and they're going to end up with the complication of hyperglycemia. Hyperglycemia is going to end up causing a lot of different complications, and we're going to talk about that in just a few minutes. Type 2 diabetes is most often related to lifestyle. So it's going to be because of obesity, because of high sugar diets, because of low exercise, things like that. The signs and symptoms. And I want to go through this because this is all really common stuff on your test and eventually on the future NCLEX. Polyuria, polydipsia, and polyphagia. Polyuria is excessive urination. Polydipsia is excessive thirst. Polyphagia is excessive hunger. Those are the three classic signs and symptoms of diabetes type 2, but there's a bunch more. Fatigue, patients tired all the time. This is for a bunch of reasons, but the primary reason is because the cells need that sugar. They need it and they're not getting it. So that causes fatigue. And if the cells don't have all the energy that they need, that's what causes the fatigue and weakness. Fruity breath odor and clusimal breathing, those are specific for DKA. DKA is diabetic ketoacidosis. It's one of the complications of diabetes type 2. And we have a separate video on DKA and HHS. But fruity breath odor and clusimal breathing may be on a test as an assessment of what should the nurse be concerned about with those findings. And the answer there would be diabetic ketoacidosis. Let's look at diagnostics. We have three different ways to diagnose diabetes type 2. The A1C is considered the gold standard of how we diagnose type 2 diabetes. The A1C tells us what the patient's blood sugar has been over the last 90 days. We want an A1C to be below 5.7. Between 5.7 and 6.4 is considered borderline. 6.5 and up is considered that the patient has diabetes. There's one more number you need to know, and that is that the patient who has diabetes and is getting treatment for it, we want to keep their A1C below 7. If their A1C is below 7, then they are considered to be at their goal. Next, we have an FBG, which is a fasting blood glucose. This is where the patient gets their sugar checked while they're fasting, and this could be on a finger stick or it could be on a blood work. And in this case, we want it to be under 126. If it's above 126, generally we want 2 or more occasions, then the patient's considered to have diabetes. And A1C, we only need one time to see that number be 6.5 or above, and the patient has diabetes. One more thing about the fasting blood glucose, you may see some textbooks say that it should be under 110, or some even say 99. So anything in that range is all considered appropriate. The NCLEX will never trip you up on that. If it wants it to be high, it's going to be above 126. And lastly, we have the OGTT. This is the oral glucose tolerance test. This is done in the United States in all pregnant women around the 20 to 24 week of pregnancy, and this is to check for gestational diabetes. For that test, the patient drinks a sugary substance, and then we check the blood sugar and we see how high it got. Nursing assessment. For a patient with type 2 diabetes, the number one assessment obviously is going to be their blood sugar level to see how bad it is. We're also going to assess their fluid level and their electrolytes. Fluid because severe hyperglycemia can lead to dehydration, so we want to check their fluids. Plus, they had the polyuria where they're peeing out a lot, can also lead to dehydration. Second, we want to check their electrolytes because sugar can really mess up your potassium. Potassium often has magnesium that gets messed up. It can cause calcium issues. So we really want to check all of their electrolytes. But if you do have a test question, what's the most important after sugar to check? I would say the answer is potassium. We also want to assess for metabolic syndrome. Metabolic syndrome is becoming more and more taught in nursing curriculums. It's already fully integrated in the provider level curriculums, but it's starting to come up in nursing exams. Metabolic syndrome is considered sort of the key risk factor for a patient developing type 2 diabetes. And what is it? It has 5 diagnostic criteria. It's where a patient has a large waist circumference, where they have an elevated blood pressure, where they have an elevated fasting blood sugar, where they have elevated triglycerides and an elevated HDL, which is your good cholesterol. If a patient has 3 out of 5 of those being above the standard, then that patient is considered to have metabolic syndrome. Metabolic syndrome is considered that you are definitely heading towards type 2 diabetes, and it's almost certainly going to happen unless we reverse course with lifestyle changes. Next, let's look at nursing priorities. The nursing priority is going to be to monitor the patient's blood sugar level, and it's also going to be to monitor their fluid and electrolytes and to make sure the patient's getting their insulin and fluids. So monitor their fluid and electrolytes, make sure they're getting their insulin and fluids, but most importantly, to monitor their sugar level. Again, we're dealing with type 2 diabetes. When we talk about DK and HHS, where the patient's in critical condition because of their diabetes, we're going to discuss that separately. But in type 2 diabetes, may monitor the glucose level. Next, let's look at treatment. Treatment, number one, first and foremost, is going to be lifestyle modifications. If you've seen some of the other lectures, you know, for example, high blood pressure. We have a bunch of different medications for high blood pressure, and given enough drugs, or cholesterol be another example, we usually can get your blood pressure down under control. With diabetes, we really can't do it without the patient's help. They have to change their lifestyle. They have to do more exercise. They have to improve their diet in order to manage diabetes. And the good news there is that in a large percentage of cases, if the patient does do those lifestyle changes, they can very often completely manage their diabetes without medication. It takes a massive commitment and a major lifestyle change, but it absolutely can be done and should certainly be the goal that you set for all of your patients. Let's talk about that treatment besides lifestyle modification, also known as non-pharmacological interventions. Moving on to pharmacological, we have our first line medication. Per the textbook, per the NCLEX, the first line drug that you're going to give is metformin. Metformin is very, very common drug that's given. It's also used for PCOS and a few other things, but we're talking about it for diabetes. And that drug is taken every day, sometimes taken twice a day. And that drug is going to lower your A1C roughly 1 to 2 points. So if, let's say, the patient came in with an A1C of 8.5, which is definitely elevated, definitely have diabetes, and they take this medication and we get them up to the right dose, we can usually bring their A1C down to 6.5, and we met our goal. Metformin is considered the first line drug for diabetes, but not everyone's going to tolerate it. Most patients will experience some diarrhea when they first start that medication. And as long as you educate them that that's self-limiting, that it goes away after they body gets used to the medication, then usually they're okay. But some patients stop the medication at that point because of the diarrhea. The other medication that's sometimes considered first line, even though it is not, for NCLEX purposes, it is not the first line, but outside the US, most of the rest of the world does consider glipizide or glyburide, same drug. We do consider those to be first class in many countries. In the US, they're second class, but in many other countries, in fact, most of the world considers that the first line drug, with metformin being the second. Now, that would be another option to give the patient. In the US, we use that as a second line drug. We do have a bunch of other drugs that we give as well, such as the GLP-1 agonist. That's very famous, at least now in late 2025. That's famous because that's what Ozempic is. We have the DPP-4 inhibitors, we have the SGLT2 inhibitors, and we have insulin itself. So all of these are different medication. There's another class of drugs I couldn't fit on here. Thiazolidinoids is another one, but these are all the different medications. Hopefully, again, lifestyle modifications by far has the most ability to lower a patient's A1C. But in most cases, we do often, unfortunately, need to go to medication. And whatever it takes, at the end of the day, we have to get that A1C down. If it takes medication, so be it. And as long as the number gets down, the patient's going to be okay. So all of these medications are going to be our options. Very often, patients will end up on 2, 3, 4 of these medications in order to get that A1C under control. Sometimes patients will end up on insulin. Usually if the patient is a type 2 diabetic going to insulin, usually we start with a long-acting insulin. So that's a once-a-day injection, and that's to keep them to keep their diabetes under control, in addition to all of their other medications. If you ever see a type 2 diabetic that takes insulin, they are always, to the best of my knowledge, I'm not an endocrinologist, but they are always going to be additionally on other oral medications in addition to insulin, because insulin is really our last resort. Let's look at the client education. We're going to educate them on medication compliance. They absolutely must take their medications. We're going to educate them on diet and exercise. That is by far the most powerful tool that we have to treat type 2 diabetes. We're going to educate them that based on the complications that can come from type 2 diabetes, which there are a lot of, they have to also be getting regular eye exams because of the retinopathy that can happen, regular foot care because of the neuropathy. They have to get regular labs, especially checking the kidneys because of nephropathy. Hopefully, you're able to follow all those. But these are all complications of diabetes, and patients need to get extra care to look out for these. We're also going to teach them about insulin storage and insulin administration, how to give the injections. We have to teach them how to recognize hypoglycemia if they're taking insulin. And then we also, of course, need to teach them that they need to be checking their sugar on a regular basis. What that is going to be up to the provider. Sometimes I'll tell patients once a week, sometimes it's daily. Obviously, if they're taking insulin, it's going to be with every dose that they take, etc. Finally, let's look at the complications. The most tested on complication of type 2 diabetes is going to be DKA or HHS. HHS is the more common one versus type 2 diabetes, and we discussed that in a separate DKA HHS video. And then there are lots of other type 2 diabetes complications because an elevated blood sugar level is toxic to our vessels. It kills our blood vessels. And because our blood vessels go everywhere, it kills everything in our body. So I wrote here vascular and cardiac issues, but that really doesn't even touch the surface. Like I already said, it causes retinopathy. It can cause eye issues. That's a vascular issue. It could cause nephropathy, which is kidney vascular problems. So it could cause kidney problems. In fact, the number one cause of patients needing going into kidney failure, needing to go on dialysis is because of diabetes. It can cause neuropathy, that the patients don't have good sensation in their legs anymore, and then they end up with pressure ulcers or things like that. In fact, again, the number one cause of limb amputation in the United States is complications of diabetes. So this is a really, really bad diagnosis to have, but patients need to be educated, and you're the ones to do that. It can also cause cardiac issues like heart attack and stroke. Again, lots to go over here, lots that the NCLEX can test you on. Hopefully, I covered everything you need to know about type 2 diabetes. Please make sure you also watch type 1 diabetes as well as the DKA HHS video to be fully covered on this topic. Hope you do great on your class and on the NCLEX, and I'll see you in the next video.